everyone. My name is Rafaela. I'm an neonatologist from Brazil. I'm a member of the membership committee from Newborn Brain Society, and I will be moderating today with Dr. Angeles. Before we can start, I'm just gonna give a few updates. So we have educational activities updates like the VOPE's views, an exclusive commentary by Dr. Volpe. We have now the call for nominations for the Newborn Brain Society leadership and committees, and a new course available about neonatal neuroprotection, and the upcoming webinar sessions is available on our website. So we also have a meet and greet breakfast at the PAS, so an exclusive networking opportunity and a ceremony to honor Dr. Alistair Gunn. And also check out the QI resources available on the Newborn Brain Society website. We have reading materials and also the QI and the education. So today, Dr. Danylin Angeles will be talking about the sucrose analgesia for preterm neonates. So Dr. Angeles is currently a professor of physiology in the Department of Basic Sciences at Loma Linda University School of Medicine, and she has over 20 years of nursing experience in the NICU at Loma Linda University Children's Hospital. So please, Dr. Angeles, you can share your screen and start the presentation, and then at the end we will have the questions and answers. Thank you.
Thank you so much, Dr. Fabri. Let me see, make sure that, all right, do you all see this? Right, so yeah. Sucrose analgesia. You already got my 3 learning objectives. If not, for this next 45, 50 minutes, I'll look at the relationship between energy metabolism and tissue damaging procedures. I will call them TDPs. Then we'll look at the effect of 24% sucrose, which is sweeties, on plasma and urine biomarkers of hypoxia and oxidative stress. Okay. And also at the end, we will look at evidence-based strategies for reducing physiological and biochemical indicators of pain in preterm neonates. Now, this work will not be possible if not for my collaboration with really important people. First of all, is Dr. Boskovic, who is a biochemist here at Loma Linda, and also Dr. Soares, a physical chemist. And then my collaboration with neonatologists at Loma Linda, Dr. Fayard, Dr. Hopper, Dr. Deming, as well as peds neurologists like Dr. Ashwell and Dr. Michelson. Many nurses helped me through these studies, Laurel and Erin and Dorothy, and Yaniesh Asmaram, through the guidance of Dr. Boskovic and Dr. Soares, developed the methods, and she performed all the purine measurements. I have several graduate students who are now scientists on their own, who also helped with these studies, as well as 2 neuroradiologists. So I want to thank all of them, the physicians, nurses at Loma Linda, of course, the NIH, NINR funded the studies. And again, many of you know this data already. The smaller the baby, the more procedural pain or tissue damaging procedures or skin breaking procedures they're exposed to. Like a recent study in 2017 by Dr. Kong showed that 23 plus or minus 2 per day. And they're usually done in the absence of analgesia. In my own study, and this is babies with asphyxia, term babies, by day of life 4, up to 35 painful procedures per day. And of course, here in a more recent one study, this is babies day of life 3 to 7, exposed from 6 to 8 painful procedures per day, up to 81% do not receive analgesia. And there's so many, all of you are aware of the association between exposure to pain and long-term outcomes. Sorry about this, why this is jumping. But, you know, some of the long-term outcomes associated to procedural pain are high cortisol in the saliva. I don't know what's going on here. I must apologize. This is moving. Okay. So you have high elevated cortisol, erosion of telomere length, lower head circumference, sensory processing problems, negative affect in this preschool, lower IQ, poor visual motor integration, smaller cerebellar subrenal volume. So these have been associated with exposure to tissue damaging procedures. Now, my personal interest in this line of work began almost 20 years ago when I looked at over 6 years, over a 6-year period, looked at the use of opioids in term babies. So I actually started in term babies. I feel like someone else is in control of my computer. But in these babies, I looked at the effect, I looked at the association between those who received opioids and those who did not. We looked at neuroimaging, MRI, and we had physicists and neuroradiologists who read all the MRIs. So we looked at the use of opioids in the 6-8 term babies, look at MRI and clinical outcome. And in that period of time, 5-6 years, we had 52 babies, and 17 of them received analgesia, morphine or fentanyl, and 35 did not. They're all equal in demographic characteristics. They're full-term babies, 39 weaker. Although those who received analgesia have lower APGAR scores, lower pH, larger base deficits. And we use the Barkovich MRI scoring system to look at the differences in MRI scores between these two groups of babies with 0, those of you who are familiar, 0 being normal or isolated infarct, and 4, more extensive involvement, or 5, looking at the basal ganglia watershed areas. And interestingly, when we looked at this, those who received morphine or fentanyl, who are, remember, these are term babies, asphyxiated, and this is before hypothermia. Again, this is between 1995 to 2000. Those who receive analgesia had significantly lower scores, meaning they have normal or isolated infarct, MRI-wise, compared to those who receive no analgesia. Highly significant. So, and then we also looked at these babies at 18 months, and looking at their PCS score, neuromotor score. Again, this is what this looks like if you're not familiar. Pediatric cerebral performance category scale. 1's normal, so the smaller the number, the better. 6 for death. But in neuromotor scores, 0 is normal, 6 is death. And notice that those who received opioids had almost normal scores at 18 months of age. So this is very surprising. And then Dr. Holzhauser also looked at brain metabolites in this group of babies. And we saw that those who received opioids, we compared them to control babies who did not have asphyxia, did not receive opioids. And those who received opioids did not have lactate, while those who had those who received opioids, 0% lactate, 40% for those who with no opioid. And then the N-acetylaspartate, which is a neuronal marker. I mean, the more neurons alive are there, the higher the number for N-acetylaspartate ratio to creatine. The value for those who receive opioids are similar to the control babies who did not have asphyxia. And those who receive no opioids have lesser N-acetylaspartate creatine ratio. So that really sparked my interest. Then we looked at the relationship between the number of tissue damaging procedures and creatine. And creatine, again, is an energy biomarker. The more creatine you are, the better it is for the cell. It means there's energy stores. And it looks like in Day of Life 2, the higher the number of tissue damaging procedure exposure, the lower the creatine. And so, and you can read the paper if you like, but my thought after seeing this study, I was just a brand new PhD graduate, is that, do opioids have a neuroprotective effect? I mean, in term babies, and if there is, if they have a neuroprotective effect, what is the mechanism of this? That's what we always do. And of course, I sent applications to NIH. That was not funded, unfortunately, and I sent another grant application. What is the relationship between pain and hypoxia? and can we measure hypoxia in babies non-invasively? And this was funded. So that's why I ended up in this trajectory. So first and foremost is the relationship between pain and hypoxia. So that means that we need to be able to measure hypoxia to be able to answer this question. And it has to be done non-invasively if we're going to do this in babies. So again, some definition. When you have lower pulse ox values, as low SpO2 or reduced PO2, that is not hypoxia, that's hypoxemia. Hypoxia means there's not enough O2 inside the cell. So there's a difference between the two. We need to be able to measure hypoxia. In the NICU, we measure hypoxemia. These are all measures of hypoxemia and not hypoxia. Hypoxia means there's not enough oxygen inside the cell. And here is probably some of you may not like this slide, this is biochemistry slide, but this shows you ATP metabolism. Notice that oxygen is important for the synthesis of ATP. If you remember from your biochemistry, if there's no oxygen in the cell or lower levels, that's called hypoxia. And what will happen is without enough O2 in the cell, this ATP, whatever ATP is in the cell, will be used up very quickly and will degrade to its metabolites, ADP, AMP, hypoxanthine, xanthine, uric acid. And our team with Dr. Bossi and Dr. Sowers were able to develop methods using very, very small volumes of blood to be able to measure hypoxanthine, xanthine, uric acid in the blood of neonates in plasma. Now notice that from hypoxanthine to xanthine, you produce reactive oxygen species. And when you have these reactive oxygen species available in the cell, well, they will attack lipids, fatty acids, cell wall, and that will create free radical marker called malonylaldehyde. Okay. In addition, uric acid, when there is reactive oxygen species, will become allantoin. So our team was able to develop methods to measure this in plasma. So now that we have the method, the question is, what is the relationship between procedural pain and biochemical markers of hypoxia? So what we did, and these are my first grant, is that, well, actually not my first grant, but for this one, we enrolled babies into a group where there's no procedures, there's no painful procedure here, or a tissue damaging procedure, where the procedure that we chose is tape removal, something that happens a lot in NICU. So 42 babies had no procedure, 38 babies had tape removal. All these babies had lines, so no one got poked, no one had to experience pain to get these values. They're 31 plus or minus 3 weeks. They're not hypoxic babies, because we want them to be hypoxic already before we even start the experiment. And what we saw is that this is baseline values of uric acid and malonylaldehyde. What we saw is that half an hour after the tape removal, uric acid levels are higher in those who had tape removal compared to those who had no tape removal. And malonylaldehyde is higher in those who had tape removal compared to those who did not. This was validated a few years later by a group, Buonocore et al. They also looked at free radicals. These are protein degradation products, also reactive oxygen species, where they saw that the higher the pain, the higher the levels of these free radical markers. So with that finding, I thought, well, if procedural pain can increase plasma markers, hypoxia, oxidative stress, will prevention of pain decrease these markers? It just makes sense, right? If pain can produce or increase markers of hypoxia, cause ATP degradation, increase ATP degradation products, well, maybe if we prevent pain, those markers will decrease in plasma. So the next grant I wrote is then to answer this question, does prevention of procedural pain using sweeties, which is what's being used at that time, will the use of sweeties or oral sucrose decrease biochemical markers of hypoxia? So it's as a grant to NIH that was funded. So we then enrolled babies into 3 groups: control group where there are no painful procedures, a group that was subjected to a clinically acquired HeLens, and were given a placebo with the pacifier with water, and then Helans given sweeties. There's 42, 45, and 44 subjects. They're the same demographic wise. They're all stable. We don't want them to be hypoxic already before we start. And so we waited 1 hour before we drew blood. Again, these babies have lines, so we don't poke babies to do these studies. We drew plasma to do baseline levels of uric acid and hypoxanthine, those ATP metabolite product called purines, and allantoin. We also do a baseline pain score. We give the study drug, which is sweeties. This is blinded. And then after 2 minutes of giving the study drug, which is sweeties, then we do Helans for those 2 groups that requires Helans, do a pain score. And 5 minutes later, we draw blood again to measure the purine plasma markers and allantoin. And we were surprised. Well, let's look first at the pain score. The baseline pain score is the same for everyone, but notice that those people, those babies who got pacifier with water only, their pain score is 6.3. With the Helans, those who got sweeties, look at the pain score, significantly lower than those who only got pacifier. And then another interesting finding is those who got sweeties, their heart rate is high, went up to 170. So they have the highest heart rates. O2 saturation is not any different between the 3 groups. But what surprises the most is that those who receive sweeties, which is this solid line, at 5 minutes, they have higher hypoxanthine, higher uric acid, and then in the group, especially who did not even show signs of pain, the highest allantoin. So uric acid and allantoin are markers of oxidative stress, and hypoxanthine is a marker of hypoxia. So something is happening to these babies that caused these markers to rise in plasma. And so, we then look and see what is this oral sucrose that we're giving babies. And so again, sucrose is a disaccharide. It's a sugar composed of glucose and fructose. It is the main constituent of white sugar. So for every 1 ml of water, if what is 24% sucrose, that means there's 240 milligrams of white sugar in 1 ml of water. Okay. When I submitted the grant to NIH, the study dose that's being used at that time is 2 ml for neonates over 2 kilo, 1.5 ml for neonates 1.5 to 2 kilo, and 0.5 ml for neonates less than 1.5 kilo. All of our babies are less than 1.5 kilo, so they all got like 0.5 ml. So if you look at it, our 1 kilo neonate receiving 10 doses of sweeties is actually getting 1/3 teaspoon of sucrose if we give 0.5 ml 10 times, considering that if they're experiencing 10 painful procedures per day times 0.5 ml, if they're getting that, they're actually getting 1/3 teaspoon of sugar, white sugar per day, which is concerning. And this is actually actually what struck me. It's published PEDS 2010 by Dr. Holstein, Dr. Grunow. They compared that if an infant who weighs 1,000 grams has even 10 painful procedures per day, and for each procedure 0.5 to 1 ml of 24% sucrose is given, we would be administering the same quantity as if we were giving a 10-kilo 1-year-old a half can of Coke Classic per day, the concentration of sugar in the Coke Classic being 11%. So that is what we were doing at that time. And another thing that I'd like to point out is the tachycardia associated with sweeties. And I don't know why their heart rate went up. I do know there's data showing that the higher your heart rate, the more calories is being burned. Your metabolism goes up, the more calories is being burned in the cells. And our babies need to gain weight. They don't need to burn calories. So that's also very concerning. Now, we looked at literature to see how does giving sweeties or sucrose cause the degradation of ATP. Now, so just a little bit of this picture was drawn by Dr. Holden, who was my student at that time. This is looking at sucrose, again, made up of glucose and fructose inside the intestines. Once sucrose ends up in the intestines, is broken down by this enzyme sucrase to glucose and fructose. Okay, so it becomes glucose and fructose. They both can enter the enterocyte, which is the cell that makes up the intestinal lumen, through SGLT GLUT2 and GLUT5 transporters. Once inside the cell, they can also, as glucose and fructose, they can leave the enterocyte, enter a blood vessel as glucose and fructose. Now, once they're inside the blood vessel, they can go anywhere, and there's many places they can go. This is showing you what happens in the liver. The entry of glucose into the cell is highly regulated, meaning glucose will only enter a cell if it's needed, right? If it's not needed, it will not enter a cell. However, fructose, its metabolism is highly unregulated. Whether or not it's needed, fructose will enter the cell through GLUT5, okay? And the bad thing is when fructose enters the cell through this GLUT5 transporter, it uses ATP. It's phosphorylated and uses ATP. And because it's entering the cell is highly unregulated, whatever fructose will continue to enter, depleting ATP. And depletion of ATP will then bring you hypoxanthine, xanthine uric acid. So this is why these markers increased in blood, because of fructose entry to cells caused depletion of ATP. And why did allantoin go up? Again, there's free radicals that are produced when hypoxanthine is converted to xanthine and xanthine is converted to uric acid. That will convert uric acid to allantoin, which is why allantoin levels are higher. So again, fructose metabolism is unregulated and leads to ATP depletion in cells. And you go, well, it's just the liver. Well, unfortunately, this GLUT5 transporter is found also in adipose tissue, the kidney, the muscle skeletal tissue, the testes, and the brain. So wherever those GLUT5 transporters are available is a cell where fructose can enter and deplete the cell's ATP stores. So that's a very, I mean, with that result, we say, well, if 24% sucrose increases biochemical markers of hypoxia, what if we give 30% oral dextrose instead? Will that decrease signs of pain and also decrease the biochemical markers of hypoxia? So I wrote that grant and it was funded. Again, a lot of collaborators for this grant. We enrolled, we have 3 groups. We enrolled them into a, where they got 30% dextrose. And this value, this dose and concentration was based on what is available at that time to be the most effective dose. It's 0.5 ml, 30% dextrose, then a group with facilitated tucking, and then 30% dextrose and tucking. So we enrolled over 100 babies into this study. There are 31, around 31 weeks gestation at the time of the study. And the same kind of thing, these babies all have lines. We didn't have to poke the babies. We drew plasma before and after. And what we saw is that those who had 30% dextrose, their PACE score during HEALANS is 7. This is the PIP score revised. Normally, HEALANS scores are at least, 9 to 13. So this is lower. Those who had facilitated tucking, 8. If dextrose and facilitated tucking is also 8. So it was very good at lowering PACE score due to HEALANS. And what is the other result we're looking for is does it increase markers of hypoxia, oxidative stress. And we look at uric acid, the numbers did not go up when we give dextrose. So we're able to see a reduction or a pain score that is lower than what's usually seen with HEALANS, and uric acid did not go up, hypoxanthine did not go up, allantoin did not go up. So after that, I mean, as we were looking at this more, we found a paper in 2002 by Johnston et al. Where they looked at babies less than 31 weeks gestation, and they found out that in babies who received more than 10 doses of sucrose per day, those babies had lower scores in motor development, vigor, alertness, and orientation at 36 weeks, lower motor development and vigor at 40 weeks, and higher neurobiologic risk scores. So that was, this actually was published before our paper. And then soon after our paper was published, a group, Dr. Tremblay, did studies on mice where they repeatedly exposed mice to sucrose in the first week of life, 10 times per day. I'm sorry about this, 10 times per day. Well, this is just moving. And they repeatedly exposed sucrose. They repeatedly exposed mice to sucrose the first week of life prior to any handling or needle prick, and then compared their brain, white and gray matter, to those who received only placebo, and found smaller volumes of hippocampus, cerebellum, corpus callosum, and striatum and fimbria in those who received repeated sucrose 10 times per day. And then Dr. Ranger et al. Also saw that those who received sucrose had poorer short-term memory in adulthood compared to controls. And the combination of sucrose and needle prick did not protect against impairment in short-term memory. Then just recently, I saw a study published by Dr. Nusier. Well, where they look at rat pups where painful stimulation during infancy increased pain sensitivity to thermal stimuli in 8-week-old rats, and sucrose did not prevent this hyperalgesia, and sucrose lowered the pain threshold. They also found when they did long-term and short-term memory tests, the sucrose pre-treatment sucrose basically increased the number of errors in short and long-term memory tests. That's concerning when it comes to sucrose. But then there's also a study, this is not a randomized controlled trial group by Dr. Schneider, published in Pain March 2018, where they looked at 22 males, actually 51 babies. They looked at MRI at 29, 32, and 41 weeks. And they looked at the relationship between MRI scores, neuromotor scores, neuro outcomes 18 months, and glucose and exposure to painful procedure. In this group, the only sweet solution they use is glucose. And they found greater procedural pain and higher glucose exposure were related to poor neuro outcomes. So that is also concerning. So now what do we do? So sucrose seems to do is not harmless. So what do we do? Well, should we use oral sucrose or oral dextrose? Yes, my thing is it should be yes, but judiciously, okay? But that means wisely, prudently, sensibly, discreetly. It's not something we can just squirt into a baby's mouth. Because there's more studies that show benefit for this sweet solution than risk. We just published this paper in Journal of Perinatology where we looked at, again, biomarkers of ATP degradation in babies who receive standard care, 24% sucrose and 30% sucrose, dextrose over day of life 3 to 7. They're 31 weekers, they're stable babies. Those who were randomized to sucrose or dextrose, the bedside nurse was given blinded study drug that they're supposed to give every time there's a painful procedure, before every painful procedure. Standard care babies, the nurses are supposed to do whatever the standard care in the unit. And what we saw is that those with standard care, 81% of those who were 81% of the babies, 60 to 81% of the babies who are supposed to receive standard care, received no analgesia, nothing. It's a pilot study. And so when we look at biochemical markers, those babies who received no analgesia had the highest uric acid creatinine ratio. So yes, this is the dextrose group and the sucrose group. So yes, do not give anything. We have to give something for now until we know better, okay? And we have better treatment strategies. So the most effect, again, when used, it need to be tracked as a medication. It's not something we just give haphazardly because it is not harmless. We don't know the most effective dose yet, although a study was just published that said 0.1 ml is probably effective. For the 70 plus randomized controlled trial, it seems like 24% sucrose, basically pacifier dipped in 24% sucrose is effective, or 0.5 ml of sucrose is effective. This is a lot, 2 ml. If you're giving 2 ml, make sure that the baby can suck and swallow and breathe at the same time. Otherwise, you may have a problem with choking. And this is from the Cochrane study by Dr. Stevens, where they found also that sucrose is not effective for arterial puncture, subcutaneous injection, insertion of NG or orogastric tubes, bladder catheterization, eye exams, and echo. And is not effective for circumcision. And then for Dr. Snyder's study that showed that there's a relationship between glucose and neurodevelopmental disorders, they saw that if a baby got 8 ml per day of dextrose, so more than 8 ml per day is, based on that study, is not good. So if you're going to use dextrose, use less than 8 ml per day. What are the alternatives to sucrose? Well, there's 38 randomized controlled trials since the dextrose is as effective as sucrose in reducing pain. Breast milk also as effective as the sucrose. And then, of course, kangaroo mother care, tucking, multi-central stimulation are also getting good reviews and in reducing signs of pain. Parents are important. Many of these non-pharmacological interventions are best done by parents, kangaroo care, massage, breastfeeding, provision of breast milk. So it's important for them to be partners in care. So what's next? What do we do? The most importantly is we need to, we only want to give the sucrose, dextrose if we know that the baby's pain. And that's the problem. We really don't know when a baby's pain. We have tools that we can use, but many of these tools are subjective. So this still needs to be answered. These are all the indicators of pain. There's facial expressions, behavior, physiological markers. And these are all the pain scales that are currently being used. And we used one of them in our studies, the PIP scoring. Now, this is a study by Dr. Rebecca Slater from the UK, looking at EEG, showing that the waveform when babies are subjected to HELANS, where there's an increase in voltage, microvoltage, from 0 to 10 microvolt when the baby is subjected to HELANS. When there's no HELANS, there's no increase in the waveform, is just almost flat. When they gave sucrose, the waveform is similar to what is seen with no similar. It looks like the baby's still in pain. So this is sucrose, this is HELANS, this is water. They're all the same. They'll look the same. There's no change in EEG waveform when the baby was given sucrose. You would expect it to go flat like this, but you see the same exact waveform. This is also very interesting, needs to be further looked at. Again, how do we know the baby is in pain? We also need to look at ethnicity, gender, and skin color. We know that these attributes are important in adults, in even in pediatrics, but this is not being looked at in neonates. Background baseline pain and stress. I mean, this is a mesenteric STO2. We look at regional O2 saturation. We saw that when we did HELANS, at this point, notice that the mesenteric STO2 dropped. Interestingly, while the STO2 is dropping here, the pulse ox was staying the same. It's not being seen in the pulse ox. When we correlated the STO2 during heel stick to the pain score, it correlated with the pain score at baseline. Meaning the higher the pain score at baseline, before we even poke the baby, the lower the STO2. And I saw this, I was in the World Congress in Pain a few years back. Sorry about this. by Dr. Riddell. She said, you can't understand pain responses after stimulus unless you account for distress pre-stimulus. So distress before the needle predicts pain-related distress after the needle. So that means that we need to reduce distress. The earlier you reduce distress, the better. So I thought that's important. We always think about, oh, the pain while we poke. How about we make sure that the baby's pain is as low as possible before we even do any poking? So again, what's next? We need to develop better quantitative tools so that we'll know the baby's in pain. We need randomized controlled trials to decrease pain scores in those that are extremely preterm, ventilated, or sick neonates. There's not really many at all studies on this group. These babies cannot suck, swallow, breathe at the same time. So putting stuff in their mouth may not be as effective. And we need studies looking at the long-term effects of these sweet solutions. Just looking at animal work published in 2018, in-year exposure to sucrose inversely associated with academic performance. So high sucrose exposure, lower academic performance in mid-childhood. And then maternal sucrose consumption. If the mothers were given sucrose, the rat pups were given sucrose, significantly higher urogenital disorders of bulbous spongious muscles. So again, even the testis is being affected. The maternal ingestion of fructose or sucrose increases concentration of inflammatory mediation in the hippocampus, and there's learning memory impairment. And in fructose itself, looking at the effect of fructose on brain development, it increases oxidative stress, increases interferes in the actions of neurotrophins important for brain maturation. It affects neuronal survival. Of course, it alters metabolism, hyperlipidemia, liver steatosis, body fat, early signs of metabolic syndrome, glucose intolerance. So, fructose is something really, I remember I'm a mother of two, grandmother of two, and I give my kids, try not to give my kids white sugar. So I wonder why we're giving sweet stuff to our babies. So again, conclusion, we need to use a validated pain assessment tool when we in the unit. We need to use them, and then when we see signs of pain, we need to give something, okay? But first and foremost, we need to minimize or decrease the frequency of these painful procedures. I understand that as brand new nurses or doctors, we have to try and start an IV and try to intubate ourselves. Others will never learn. But the younger the babies, I think we only try once, and if you can't do it, let someone else try start an IV. Let someone else intubate, because you can't really try over and over. It's harmful for the baby. And then if there's pain, provide analgesia. For mild to moderate tissue damaging procedures, use sucrose or dextrose or breast milk. I think dextrose or breast milk. Skin to skin care, tucking, swaddling, sensory saturation, again, involve parents. For those for this population, we need more studies. And again, more studies on the repeated use of sweet solutions. And I'm sorry if I spoke too fast, but I'm done. If you have any questions, I welcome it.
Thank you so much, Dr. Angelis, for the amazing talk. We received questions here. I think maybe we can discuss them. The first one that I would like to do is, at what age do newborns start producing sucrase? My understanding was that premature infants do not produce sucrase before 37 weeks. Can you comment this?
That's a good question. I think they're not supposed to be there, but it depends on nutrient availability. So when the nutrient like fructose is presented to the intestinal mucosa, then that is when they are produced. So the sucrase is available. Also, it seems like babies given corticosteroids produce this. Not only they get sucrase produced, they also have the GLUT5 transporters expressed. So nutrient availability and also drugs like corticosteroids.
That's great.
Mhm.
And another one, so it's counterintuitive to think that sucrose supplementation will decrease ATP production, as simple sugars in infants' diet are known to provide energy to infants. Could the increase in allantoin, uric acid, or hypoxanthine that you observe be an effect of increased flux to glycolysis and pentose phosphate shunt ATP production?
Okay,
So
so you are the biochemistry question. So I'm trying to read again. So the increase in allantoin, okay, increased flux to right? Basically, the reason why you have higher levels of uric acid is that you have cellular entry of fructose into cells. And when fructose enters cells, it's phosphorylated by fructokinase, which is ATP dependent. So fructose enters the cell and it uses ATP to become phosphorylated. Okay, more fructose, more ATP is used. So it basically steals the phosphate inside cells in order for it to be phosphorylated.
perfect.
Yeah.
So, and also commenting about the possible effects of this reduction of pain, less pain, and associated with better growth. So, what you can comment about this?
So I'm sorry, say that again. Less pain is better growth. But I'm sorry, say that again. What is the question again? Sorry.
So, I think the first one, like the relations between if there is better growth, if we can control the cortisol. So I think it's a thing for next steps.
Oh, okay. So you're looking at the relationship between growth and pain management for sure. Yeah, and I mean for the brain for sure, it seems to be controlling or minimizing pain is better for the brain. Now, growth when it comes to just metabolism or growth of the individual, there's many studies. I look at there's 35,000 papers on the effect of fructose on metabolism. Using fructose, eating in your diet increases the risk for obesity. Okay, increases the risk of metabolic syndrome. So we want to prevent pain, but we want to prevent pain using strategies that will not deplete the cell of ATP or lead the baby on a path where they will start storing and creating, because the end effect of too much fructose in the cell is the creation of fatty acids and triglycerides and cholesterol. That's one of the side effects that I didn't go over because this is a newborn brain society talk. I didn't go over the effect on metabolism. But yes, it's important to prevent pain because preventing pain is better for the brain. But we need to find ways to prevent pain where we're not going to alter metabolism and cause the cell to have to deplete its energy stores just to tolerate and to accommodate the fructose, the sucrose we're giving.
That's great. And also, based on your presentation, if colostrum is not available, do you think giving a little bit of donor milk or formula is better than sucrose if we have the consent time?
Well, there's a lot of studies. There's several studies on breast milk that's saying that breast milk is effective at reducing pain scores, is as effective as sucrose in reducing pain scores. The interesting thing about breast milk is one of my slides that I just show is that breast milk now has fructose in it. Because what's happening is if the mother is eating, for example, sweets, there was a study where the mother was given Coke, and they measured the fructose in Coke within 3 hours in breast milk. So just because you're giving breast milk doesn't mean that you've escaped the fructose sucrose problem. I don't know if the NICUs right now are checking for sucrose or fructose in milk because now there is fructose in milk because the presence of this carbohydrate depends on the mother's dietary habits. But yeah, dextrose, sucrose is in breast milk. But I think if you, instead of giving just flat out sweeties, yeah, I think formula or breast milk is better. They said, fat is the best, right?
Yeah. And also about the dextrose gel. So can dextrose gel be used to treat pain? And also in fasting patients, sucrose or dextrose can be used.
That's a good question. I've heard about dextrose gel. I have not really investigated that. I don't know any studies have looked at the use of dextrose gels for reducing pain. I mean, so I can't really recommend anything that I have not read or studied. One thing about dextrose, we're worried about the potential neuro effect of dextrose. Dextrose is something we give to babies. D5W is 5% dextrose. D10 is 10% dextrose. D12 and a half is 10% dextrose. So for those long-term studies, how are you going to differentiate between the dextrose that you gave orally for pain, between the dextrose we're infusing on the vein? Dextrose is something we give naturally to babies. Fructose, sucrose, we don't give that. Even ourselves as mothers, we try not to give our infants any type of anything with white sugar. So that's a struggle, I think, and looking at the long-term effect. Because dextrose is something we already give. We've been giving it for years. So.
And one other questions is, does sucrose interfere with blood glucose level in newborn who has risk for hypoglycemia?
In all of our studies, we always check did the chem strip after, like, within at least 2 hours after we did our study, to see if the sucrose we gave changed the plasma glucose level. It did not change it. Okay, in our studies. Okay, so these are one time we gave the sweeties one time, 2 hours later, 1 hour to 2 hours later, we checked blood glucose, no effect. In other studies, I saw one study where it seemed to have increased glucose level, but in my own studies of over 400 babies, I did not see a hyperglycemia or hypoglycemia.
And another question is, in the study that you presented, the higher painful procedures and glucose administration, the higher neurological impairment were found. So could it be that glucose in the study had just a confounding effect, and then just the pain is leading to more neurological impairment?
Yeah, excellent question by Dr. Snyder. I read that paper, and they admitted in the paper that the babies in that study hardly got any glucose. For every 10 painful procedures, 0.1 ml glucose was given. So the group actually is an untreated group, okay? So for every 10 painful procedures, 0.1 ml of glucose was given. So I'm like, okay, so how do you, how do you then connect? I mean, it's not you cannot do this an effect study, cost effect studies, association study. So they themselves admitted that it's probably an association between the number of painful procedures and not exactly glucose. But that study, all they gave was a glucose. But for every 10 painful procedures, 0.1 ml. So I don't know. You can just think about that and see what you can conclude from that data.
And you also comment about the assessment tools for really assess the pain and if need or not the sucrose. But in your experience in the NICU, when you have no score for pain in that moment, just to prevent a pain for the procedure that's coming, you always try like skin to skin and positive touch, or you give something like prophylactic to the procedure that is coming.
Right. Yeah. I mean, some babies, like the babies I showed in the Sucrose study, their pain score hardly changed. but they're the ones with the highest allantoin tone. So this is why the pain tools we have does not necessarily are not all accurate. It looks like the baby's not in pain when in fact they are. If you look at the biochemical picture, they are showing signs of, I mean, at least free radicals, right? Free radical damage.
And for the last comment, could you mention the take-home learning points for this section, please?
Take-home learning. There's a lot of discouraging. I feel like it's discouraging news on sweet solutions, but still, we have 70, at least 70 studies that say that use of this sweet solutions for mild to moderate pain does reduce pain scores. So I think we should use what's available. That's what's available, all right? I will not personally use sucrose. I will use dextrose or breast milk. I will use kangaroo care, multi-sensory stimulation, anything to avoid the sweets, right? But we cannot not do anything. We can't say, well, I don't want to use sweeties because it's bad for you. Well, there's other things you can use. Dextrose, breast milk, kangaroo care, tucking. Use something because it is not ethical to not use anything. And then again, I mean, assess for pain. I mean, we need to be looking and we need to be intervening. So that's my take home.
Thank you so much, Dr. Angelis, for the excellent talk and discussion. I just want to thank you, everyone that attended for this session, and we will end the record. So thank you so much. Have a nice. No, here it's evening. I don't know there.
Yeah.
Bye bye. Thank you so